Good morning. How's everybody? We're going to quickly get underway. My name is Mick Cody. I am the field CTO for Elisity. I have been working in the industry for almost 30 years. I'm a former retired partner from PwC. I actually worked and ran with a bunch of other people the healthcare vertical for PwC for a period of time. I've been working in this space in both breach response and a lot of different avenues. But today I'm going to sit here, introduce Taylor, and we're going to talk about what happens when securing devices that can't, what happens when they go offline. Taylor?
Yeah, hey everyone, thanks Mick. I'm Taylor Colloni. I'm a Cybersecurity Engineer at Southern Illinois Healthcare, or SIH. Been there a little over 4 years now. Previously from there, I worked at our local university, SIUC. And yeah, we're gonna go in about how we changed our microsegmentation program at SIH from nothing to full deployment.
So let's talk about that, right? So let's set the stage for everybody. When you were talking about this, you know, we have the securing devices that can't go offline. I mean, everyone here probably knows that it's kind of important when you're dealing with patient care. How do you define that for you for SIH, and how you kind of went about thinking about this as you develop the program?
Yeah, no one can go through a network redesign. No one's got the money for it. No one's got the funds or the resources. And, a lot of these devices that are FDA compliant or just medical devices can't take agents. A lot of the solutions out there were agent-based where you can't get full visibility. So one thing for us was full visibility on all our assets, as well as implementation partners to enrich the data the best we could.
Right. So a lot of people struggle with the segmentation conversation, right? There's a lot of different approaches that can be taken, but you have to have a catalyst. Like something has to spark and say, look, we're going to stand out. Not everybody in healthcare is even, we all need to do it in healthcare for sure. But as an industry, we tend to lag behind. What was the catalyst, or what was the key kickoff point or thing that kind of drove, SAH and you as a team to kind of get going on this?
Just finding a solution that worked for us. There are NAC solutions out there that, again, you got to redesign everything, or there are very expensive solutions that you need FTEs for, and we didn't have that. We're a regional healthcare facility that's strapped on a budget. We're a level 2 trauma with 400 beds, basically from the Mississippi River to the Ohio River, and we can't have downtime.
Right. How many counties is that? How big is that space?
Roughly 17 to 19.
Right. Okay. So you kind of alluded to visibility, right? So we all struggle with that. I think in healthcare we're getting better and better. There are an awful lot of solutions now that are supporting and helping us find them. But you can't protect it if you can't see it, right? Ultimately, and that term can be overused. So define what that looks like for you in visibility when it started down the path of segmentation.
So when it started, you deploy AD agents, endpoint agents. Stuff gets missed or stuff gets excluded, and then you don't know where that device is, what it's connected to. It's touching a switch somewhere, but you don't know which one, and if it's in a spreadsheet somewhere or written on a notepad. So we were looking to tie in best we could there.
So what were kind of some of the inventory points of view that you were using to gather that? I know obviously we had a part to play in that from visibility. What else were you using to enrich, to create context?
Our Claroty Medigate solution for IOMT security, our CrowdStrike, our EDR agent was out there. We had an IPAM solution that it's manually configured. So then you're looking at IPs or MACs and spreadsheets.
So moving forward, and when you talk about some of these parts, right, particularly in a hospital setting or in a particular situation when you have trauma center, all these things, as you approach going about doing this but causing little to no disruption, how do you stage gate yourself for success, obviously, so you're not impacting clinical care? What does that look like?
Yeah, I mean, with the program of Elisity, we were able to enrich all that data in the platform, and then we can see the network flows. We can triangulate the device, make sure we know what it's doing, what it's talking to, what it says it is.
Right.
And then we were able to put policies in simulation mode to monitor the activity to make sure we're not going to disrupt patient data. We're not going to take that device offline.
So were there categories of how you established which sites to start with versus, like, so the audience would capture, how do you do it? Different hospitals with us have done it different ways. What did it look like for you? Did you pick a specific site grouping or style or quantity? How did you determine where you were going to start?
Yeah, well, for starters, the POC we started at our cancer institute.
Okay.
That's only 8 to 5, so we were able to go in after hours, kind of play, deploy, break, or fix, just make sure it all functioned. Post that, we started at our main hospitals to be able to enrich as much data as possible.
Right.
So we started at our biggest site, dwindled it down from there to the smallest, and then we branched out to all the remote clinics.
Okay. So on the last site, is that like kind of the heartbeat of the system that you were kind of monitoring? Like when you went about doing, say, the 400 bed, was that the last of the last that you were kind of starting, or looking at from what you were doing as you went that? Or did you even break that down floor by floor?
We had to break it down floor by floor. We needed to do some switch hardware replacements. So the network team did have to schedule downtimes for that.
Right.
But that wasn't necessarily the platform. So that one was last. It was floor by floor. But then once the hardware was replaced, we had Elisity on the switches and we're finding devices and monitoring.
Right. Okay. So the ultimate, what we find in healthcare all the time is obviously trying to do as much as you can with least amount of what you can, and that generally means humans, right? Resources.
Right.
What does this look like for you using this type of a solution in conjunction to what it looks like now post? Like, what does that workload look like? Have you found a way to ease of, admin, overhead, all that kind of part,
Right. So pre-solution, we just couldn't get the bandwidth to do it for the other solutions. Now that it's been deployed, Elisity was my main project for probably the 2-ish years of getting everything rolled out. Since then, it's almost hands-off. I'm in it maybe 5 to 10 hours a week, just either doing granular changes or granular policy enforcement. It's very low overhead once it got running. We haven't had to add any resources.
Really? So if you look at would you have said you would have had 4 or plus kind of doing the whole network infra? If it's taken the load off, you're able to redistribute those resources into something, meaningful. They're always doing something meaningful. You'll always get something going, but you're able to redeploy now for project-oriented kind of capacity. Is that what you've kind of allowed yourself to do these days?
Oh, yeah. The network team that deployed the switches, there were 2 of them doing our entire switch stack across all the sites, and then I, on the security team, was the main admin in Elisity. We had 3 total resources for full microsegmentation.
Interesting. Okay. So going forward, and as you kind of describing again, getting back into this, and particularly I'm sure these are the kind of questions people want to learn and know. So from the big thing, what were the gotchas? What surprised you the most going through that kind of a journey?
How fast it was. Our network or our security director was late. He had an obligation to our POC with Elisity, and within an hour, it was deployed on a switch, monitoring and blocking the devices that came in, and it was like, this isn't real. So,
right.
So then we started deploying it out in the wild, and I kept waiting for the moment that's like, okay, something's got to break, something's got to give, and it just didn't. It just worked.
So if you look at that, and I by the way, full disclosure, I've only been here like 12 to 14 weeks myself. I am in awe of how it works myself sometimes. But so there's a lot of leaders that go about this, and I know some of the people in the audience, in fact, who've gone through some of these missions. Microsegmentation is, we've talked about it for over a decade. It kind of tends to be this, kind of a leery auspices of things that kind of, well, this is what it means to me. This is what it means to me. So if you were to give advice, quote, from an engineering leadership perspective of somebody who's running a program like this now, what would you say are the key things that you would pass on? Like going back to Nathan, or going back if you were to go to another system and go like, hey, these are the things you should be thinking about. Mm-hmm. Obviously you cover what surprised you. That's good. But what are the things you would give as upward feedback to leadership going through the program?
That it's doable. Microsegmentation is a scary word in security and networking because how do we tackle this? How do we build a program around it? And then with Elisity, it's just doable. You just set it up, knock it down, build a program to get through it. What
was the overall kind of like aging situation throughout the environment? Obviously, you're serving both the community that's in and around the greater St. Louis area, southern Illinois area. I mean, did you have aging equipment? Did you have things like you talked about upgrading some of the switches? That's kind of a normal thing. Were there any other kind of aspects in that kind of, that we all deal with in healthcare where there are machines or things, imaging maybe sitting there, could be upwards of 20 years old? How did that work when you started categorizing what you were doing to approach, kind of segmentation around those devices?
Yeah, so we did, like-minded devices, whether it was imaging, infusion pumps, radiology equipment. But if they were a certain operating system and we could segment it off the internet and kind of isolate it by itself, but still allow it to talk to what it needed to talk to, we were able to do that.
Right.
One thing that everyone, I'm sure, hears is, you've got an old piece of equipment, you isolated it from the network due to its age or due to its vulnerabilities or what have you, and then all of a sudden the vendor comes to you and says, we need to put that on the network because we need to archive the data from it to upgrade you. Everyone's favorite. Right. Now we got to put this vulnerable device back on the network. So with Elisity, luckily, all I do when that question comes up, it's very adaptable. I just get the MAC address from the individual, from the tech working it, put it into the program before it even touches a switch. Internet only. The vendor can do what it needs to do, pull it right back off the network. So it's changing the rigid security roles of, no, you can't do that. We have an exclusion policy. You're not putting that on the network too. Yeah, I can help you with that.
Right. So what does it look like now on a go-forward strategy? So it's not going to be uncommon with either infusion pumps, radiology, and all of the above when it comes to that specific type of equipment in any given floor. So now what do you do? What do you think the go-forward strategy looks like when you get a Class 1, Class 2 FDA recall on a device? It's not uncommon that you may have to leave the device sitting there for maybe 2 months, 3 months, 6 months.
Right.
So what does that look like when you have to kind of quote unquote leave it online, offline, knowing that there are Class 1, Class 2, work that needs to be done? How do you think it's going to look like doing that kind of work going forward?
For us, it'll be restricting it even further. Okay. Getting more granular with the policies. Right now, our wired network is 100% segmented, but it's a lot of off-on. We're getting granular with that to talking with vendors and the teams and the actual ports required in the services to restrict it down and refuse comms to, say, a PC or a card system on the network.
So when you look at speed and time to value, if you want to call it that allowed you to get there from doing all of that, were there any other differences? So as you started categorization, microsegmentation obviously breaks down into, you have a lot of other auspices. It's not just traditionally the med device, it could be IT assets. What about the greater, parts of running an operational, you're running a hospital, right? Mm-hmm. And you're running clinics. So when you look at that, if you were to look at it from a patient perspective, as you enter the facility, right, mm-hmm. from intake to discharge, as you're going through that, how would you now categorize what you do when you look at the assets that kind of attach themselves to the human mm-hmm. as they go through the continuum of care? What does that help you redefine now what you're going to do going forward as you start to lock down or think about deny or approve or, allow from that perspective? Yeah,
we're not the only facility, but we're the biggest facility in the area. So I've been a patient of our own system, Right. So I go in and I'm like, wait, I know that bedside monitor used to be able to talk to the wrong server or someone's PC in registration.
Right.
Or the network jack on the wall that's free. So now it's, I can see of what I've done and what we've done as a whole, and I can feel better knowing that if someone wants to come in with a rogue device, they're going nowhere on the network. They're wasting their time.
Right.
At least if they're trying to get on the network.
Right. So speaking to that, so when you were going through this inventory of visibility, obviously you're using Medigate for one part of it. Was there anything that showed up that was kind of another shocker that you didn't know about that was seen, obviously from the way the visibility operates, from the switch down?
Yeah, a bunch of shadow IT. Yeah. We found our hospitals have a couple tube systems to send stuff around. Well, there were local NAD bound Windows 7 machines plugged into the jack, internet capable, that I was like, there's no spreadsheet, there's no documentation of this device. Why is it here? who can I talk to, where can I find it, and kind of remediate it, get it off the network, or upgrade the system.
Interesting. So, our friends on the clinical side, I'm assuming that were,
Yeah.
Okay, so they went down to the Best Buy, did what they did, and ended up on the. So, how did you? So we're talking about segmentation. We're very we're on the technical side, but there's also you got to manage this from a political side. How did those conversations evolve then with you and Nathan?
Well, he really controls me, really reins me in, because I want to go just scorched earth. As any security professional does, and just get it off my network, get it away from me. It keeps me up at night. But it's a conversation of educating those in that clinical world and go, okay, let's control what you have besides just say no you can or yes. No one likes to hear the word no.
Right. Of course.
So if you've got an old MRI or you can't afford to upgrade, or we can no longer just hit you with no, but here's what we're going to do moving forward. We can meet halfway and let me talk to you, the vendor. We can all get in a meeting together and we can segment the device and everyone can be happy.
Right. So it's kind of a distinguished thing to bring parallel, right? Obviously the world has shifted into much more of wired wireless, where one side more technically apt or easy to do than one or the other. Was there any, or was there little or no difference? How did that look like when you were going about to do the segmentation?
So wired was real easy. And of course, you've got your IT conflicts. The network team doesn't necessarily want to give up wireless. It's not flat. It's got ACLs on our wireless network. But now we're starting to have the conversation of let Elisity handle the wireless, get rid of the old system, get the old ways. We have the visibility and the monitoring capability to do it.
Okay. So kind of in getting close to closing here, if there were, we kind of addressed a couple of different things on thoughts, gotchas, surprises, good things, right? Mm-hmm. Also odd things that you found. Sitting from where you sit today and now going forward, if there's advice to people who are sitting in the audience, how would you set the stage for where, sitting from the seat or the throne you sit on now, which is good. You're managing risk better. You're managing all the visibility, all the good things that are happening. Segmentation is helping. Where would you go if you're saying, hey, come talk to me. I'll give you kind of the stages of success. What would that look like?
Yeah, it would be, what do you need to do? Because we needed a platform to be our source of truth on the network, and we were able to find a program like Elisity that would integrate with the tools we had to enrich the data. And then you need to look at speed, resources, and what you believe you can get done with the program.
Right. Well, you referred to earlier about the catalyst. Was there any internal audit pressure, board pressure, leadership type pressure, like the looming conversations that are still going on with HIPAA requirements, addressable, non-addressable, right? So any of that play an impact in helping kind of move the needle on like funding, for example?
Yeah, we had a little leadership change, which is security focused, so that helped free up some money. But also our cyber insurance issuer was keen to let us know, like, hey, you got to have something for segmentation. You can't just tell me you've got a guest network and a prod network and some other things. So the insurance issuer really led us to, okay, let's go find a solution. Let's go find what works for us.
Really? So was there a change in liability? Was there a change in overall structure? What that insurance looks like now today versus what it is? Is it obviously hopefully reduced?
Yes.
So
there was a reduction in cost. Of course, I'm the engineer, so they start talking business, I walk away.
Right.
But there was a reduction. There was a premium reduction in what was there.
Okay, excellent. So I want to thank you. Any questions from the audience on this kind of a journey that we've taken with Southern Illinois? Any questions at all? None? No one's any bashful? Want to jump up to the mic, have a conversation? Come on, Lenny, I know you'll want to have a conversation. Well, I appreciate everyone taking the time with myself. Thank you, Taylor, very much for taking the time. Appreciate it, you guys. Take care.
Thank you.